Now our final speaker, Dr. Ajeet Bhadoria, Additional Professor, All India Institute of Medical Sciences, Rishikesh. It's all over to you.
Thank you so much, respected chairs and dear friends. So today in this talk, I'll be talking about what is about epidemiology of hepatitis A and E in India and how it is changing with time. So this is how we are seeing the cases of hepatitis A in India mainly. A young kid, college-going student comes to you with some history of fever, jaundice, with raised ALT to a level of 2,000 to 3,000, INR 1.7, and family says that in the hostel mates, they have also seen jaundice. So that means it's like an outbreak of hepatitis A in a hostel, and one kid is ending up into a severe acute liver failure case. So you order for hepatitis B surface antigen, NTHCV also, and then you go for IgM-A, HIV, IgG also, and then finally you try to make a diagnosis, and you see that it is acute hepatitis, which is converting into fulminant hepatitis and leading to liver failure also. So nowadays, it's not a disease of pediatric illness, hepatitis A, as mentioned by Dr. Vivek also, and even Nick, that now with changing epidemiology, we are getting more susceptible adolescents and more susceptible adults, and the chances of getting severe symptomatic infection and acute liver failure is very high. So if we go for a natural history of hepatitis A infection, you can see mainly it is asymptomatic in children, more than 70%, and it is more than 70% symptomatic in case of adults, and leading to higher chances of relapsing hepatitis or prolonged cholestasis or acute liver failure, even ending up into death and sometimes liver transplantation also. So is HIV or hepatitis A becoming more common, or it is changing epidemiology? So as discussed earlier, because of improvement in hygiene, sanitation, development, urbanization, whatever you call it, there is improvement in hygiene and sanitation, and the kids at the early age, they're not getting exposed to hepatitis A. And then we have adult people or adolescents who are susceptible to hepatitis A infection, and when they get the infection, it is more symptomatic and more severe. So when we talk about endemicity, there are different criteria according to WHO. So initially, India was in high endemicity. Now we have moved to intermediate endemicity. What does it mean? It means that if the age of getting infection with hepatitis A is increasing, then you are moving towards low endemicity. That means most of your kids, they do not get infection at an early age. And that leads to increased number of susceptible adolescents and susceptible young adults, which are at higher risk of getting symptomatic infection. So India, if you see, most of the states, they are into intermediate endemicity as compared to, there is only one state which is in high endemicity. Else overall, you can say that India has moved from high to intermediate endemicity, and now that's why we are seeing this changing epidemiology of hepatitis A. So if when I looked for the review of literature, so whatever available seroprevalence data for hepatitis A IgG antibody, so the main catalyst is sanitation, and then the paradox which we are seeing is that early life exposure is less. And in the last right corner, you can see now from the middle one, 1980, 1990 data shows that 100%, nearly about 100% of the kids, they get hepatitis A infection during their initial phase of childhood. But now from 2017 to 2021, you can see this prevalence has gone down to 45% to 40%, increasing, more than half of them, they are susceptible to hepatitis A infection in their early adulthood. Second, I tried to triangulate the data with hepatitis A attributed acute liver failure cases, and now it has been seen that more cases of acute liver failure, they are occurring because of hepatitis A, as mentioned by Dr. Vivek also. You do the transplant for such cases who may need transplant also and sometimes die also. So you can see from the rising graph that it is around 90% of the acute liver failure, viral hepatitis of ALF cases are occurring because of hepatitis A. So clinical outcome is also very poor when it occurs in the later age, 50 to 78% mortality rate without liver transplantation. And it's very difficult to arrange that amount of money for liver transplantation and to get somebody who can donate liver from your family. So if we talk about vaccination, as already is discussed by Nick, so in India, we have vaccine available in the market. It has been recommended for children, but not in the universal immunization program. So it's not freely provided to all kids, but it is available in the market and is used when and when required, or when a pediatrician feels like it's required. So we have both double dose and single dose available, and the cost is around $20 per single dose in India. I've given it to my kids also, so it's around $20, but it is on the family or on the pediatrician to whether give or not to give. So there are multiple implementation options which are available now by seeing this changing epidemiology to at least immunize those people or vaccinate those people who are living in higher socioeconomic status, children, or those who are going out from the school. We can check them for antibodies, and those who are IgG negative should be given hepatitis A vaccine. Even in chronic liver failure, also chronic liver disease cases, also they need hepatitis A vaccine because hepatitis A infection in these CLD patients who have a etiology of hepatitis B, hepatitis C, MASL D, or alcohol, if they get hepatitis A, it can end up into acute on chronic liver failure also. And then definitely for those travelers who are coming from developed countries in India, they should also be vaccinated. If we talk about hepatitis E, in India is high endemic zone, and we have mainly genotype 1 and genotype 2 as mentioned in the map also. And the developed countries, they are mainly low endemic zone. They have genotype 3 and genotype 4. So burden for hepatitis E, if I talk specifically about genotype 1 and genotype 2, which is through fecal-oral transmission, it's around 20.1 million total incident infections, 3.4 million symptomatic cases out of this, 70,000 deaths, and 3,000 stillbirths. So hepatitis E is something which is not only threat to an individual, because as mentioned by Dr. Vivek earlier also, it leads to more severe infection if the infection occurs in third trimester to a pregnant woman. So the life of the pregnant women is also at risk, and even the outcome of fetus, the loss of fetal loss is also there because of stillbirth. And similar to hepatitis A, we are also seeing the decline in hepatitis E seroprevalence, similar to hepatitis A, keeping more adolescents and more adults susceptible to hepatitis E infection later in life, and specifically in the women of reproductive age group if they go for childbearing. This is the study which is done recently and published in India among the seroprevalence of hepatitis E in pregnancy, and you can see that there is high seroprevalence of hepatitis E in pregnant women, and there is also socioeconomic and nutritional factors which increase vulnerability to hepatitis E infection. So there is a need for hepatitis E vaccination in reproductive age group before they go into conception or before marriage also. So pre-marriage or pre-conception counseling can be done, and hepatitis E testing can be done, and vaccine can be given if it is required. And why I'm mentioning this? Because there is disproportionate mortality in pregnant women. So overall mortality because of hepatitis E in general population is only 0.5 to 4%. But when it occurs in pregnancy during the third trimester, it rises up to 15 to 25%, leading to acute liver failure, severe obstetric complications, death also, and even increased intrauterine death and loss of fetus also, and stillbirths also. As mentioned for hepatitis A, hepatitis E is also a leading cause of acute on chronic liver failure. That means you have underlying some chronic disease or cirrhosis because of any reason, and then you get hepatitis E infection, the chances of getting that acute liver failure is very high. So in India, the data shows it's around 66% of ACLF occurring, they occur because of hepatitis E. And prevention is simple. We don't have any antiviral treatment for hepatitis E. We don't have any antiviral treatment for hepatitis A also. Only the prevention is something which can prevent the population. So we have very good vaccines for both of these hepatitis A and E, which can be used, and at least can protect both CLD patients also, and even pregnant before pregnancy. So for hepatitis E vaccine, we have a DGCI. DGCI is Drug Controller General of India, and they have approved this hepatitis E vaccine in August 2025. And there are two manufacturers which are from India, Uric Pharma and Dr. Reddy's. And this is a recombinant vaccine. There is enough data to document about the efficacy of this vaccine, which is around 87% at 10 years after the vaccination. And it is recommended in 3 doses, 0, 1, 6, like hepatitis B vaccine. and it is very promising. But there are some evidence gap for specifically for pregnancy and for immunocompromised host. But at least we can target CLD patients to decrease the chances of ACLF-related mortalities, women in reproductive age group, so that the chances of getting maternal mortality can be decreased. So overall key take-home messages is that India is moved from high to intermediate endemicity, and this is which also has some geographical heterogeneity also. And this transition is now creating a larger number of susceptible adolescent and adult cohort in the country. More symptomatic hepatitis A infection, more acute liver failure, attributable hepatitis A related or E related ALF burden, ACLF burden, and more outbreaks are occurring in the country now because of this increase in susceptible population. Hepatitis A vaccine is important. We can push for inclusion in the universal immunization program, but at least it should be risk and context informed, and not purely routine versus non-routine. We can have some targeted groups which can be initially targeted, and then we can go for universal immunization if required. Similar for hepatitis E, also it is a significant threat for those who have chronic liver disease, and also those who are planning for pregnancy, leading to death and also fetal loss also. So there's a strong rationale and benefits of hepatitis E vaccine also, but Indian context needs wider discourse to take a decision on hepatitis E. So that's all from my side. I'll be happy to take questions.